Also, thanks to Rupa and the whole organizing committee in this IBD-ENC platform. I'm delighted to participate. So the brief given to me was COVID-19 vaccination in IBD and what is new. On this note, I do not have any disclosures, competing disclosures. So really, these are the current approaches to viral vaccine development. On one side, on the right, on the left, is the live attenuated old and traditional models. We have also quite a bit of the whole inactivated vaccines. Nowadays, we have the very newer technology, which is the RNA technology. Some of the older recombinant technology has been there for a few decades, the recombinant viral vectors and the recombinant bacterial vectors. And to put things in place, what are the names that are assigned to all this? The Sinopharm, Sinovac, Bharat Biotech are really the whole inactivated viral vaccines. The Pfizer, Moderna, and the Acurus Duke NUS venture is the RNA vaccine. And for J&J, AstraZeneca, Sputnik, and CanSino, these are the recombinant viral technologies. So really, for a vaccine, we really need to understand what makes it effective. Certainly, there are many host factors that will impact on that. Certainly age, people who are older tend to have a lower efficacy. For some reason, females may have a higher response rate. Dr. Siu alluded to pregnancy, and perhaps there could be some impact on vaccine effectiveness and safety. We do know obesity does change the effectiveness of vaccines, and so on and so forth. And really, certain chronic diseases can certainly do that, along with some previous immune history, genetic polymorphism, and interestingly, microbiota. So also we have in many of our patients, oops, I'm sorry. Sorry, I skipped many slides. Gosh. Sorry, let me take it all the way back. Just for having grubby hands. Okay, so just talking about, obviously, there may be many reasons for why we subject a patient to immunosuppression. And in IBD patients, obviously, there are a lot of drugs that actually can immunosuppress the patient. And we'll probably talk a little bit about what are the drugs that may have impact on effective development of neutralizing antibodies. But suffice to say, our patients with IBD, really live vaccines should be contraindicated because there's always a risk of disseminated infection. So looking at, we've been hearing that perhaps is it true or not, and based on the survey that Dr. Rupa sent out to the respondees, and a lot of discussion, a lot of answers have alluded to whether anti-TNF might impact the effectiveness of vaccine. So the reality is, if you look back at some of the old vaccines that are in place and whether we have used anti-TNF, you find that there's no consistent answer. Perhaps in hepatitis A and B vaccine along influenza, there is some impact when you use anti-TNF onto the vaccine's efficacy. But if you use pneumococcal and you use the tetanus or pertussis, you find that actually the vaccine is fully effective. So I think really the point to be made is that perhaps it has to be individualized. We have to study to see whether, COVID vaccine is effective in our patients with anti-TNF. So this is currently what it is out there. These are the vaccines that have been approved in various jurisdictions and various countries. And the mRNA ones are essentially Pfizer and Moderna. The non-replicating viral vectors are AstraZeneca, Johnson & Johnson. And in many countries around the world, Sinovac and Sinopharm have also been approved for use. There are many in the pipeline, but they are all not ready for discussion yet at this point. So whatever the case is, if you look around at the medical societies that look after patients with immune-mediated inflammatory diseases, be it in rheumatology, be it in inflammatory bowel disease or dermatology, all of them consistently tell us that they support SARS-CoV-2 vaccination in all our immune-mediated inflammatory diseases, including IBD, of course. So what we don't know is, are there differences in how vaccines are effective in different, when we use the nucleic acid-based vaccines versus viral vector vaccines? Well, the reality is that the data is slowly emerging. We are beginning to learn a bit more, but at the moment we have a few observational studies that may guide us to understand this a bit more. So one of the three studies that I'm going to highlight today in a short time is the first one is a small study, single center German study, basically looking at a variety of immune-related diseases ranging from rheumatoid arthritis, psoriasis to IBD. And the vaccines used included essentially the two RNA vaccines, the Pfizer and the Moderna vaccine. More importantly, in this small cohort of patients, all of them could mount antibodies to spike protein, meaning the neutralizing antibodies were detected. And interestingly, more importantly, the disease activity remained stable post-vaccination, because I think we wanted to know, just like Sue presented, does COVID infection aggravate IBD? We also want to know whether the COVID vaccination aggravates the disease state. So the short answer, at least in this single study, small number, the answer is that the disease does not get impacted. More importantly, also, safety profile is similar to whether to healthy controls. Yeah. So of course, these are small studies, so we really need bigger studies. Two more studies which I would like to quote, and one of them I'm going to go into a bit more detail, is the Clarity vaccine sub-study. Basically, this one shows that at least after one dose of the vaccination, be it the Pfizer BioNTech or the AstraZeneca one, the seroconversion rate was slightly lower in the infliximab arm versus the vedolizumab treated patients. However, a second dose led to seroconversion in most patients. On the other side, there's another study from America, basically looking at seroconversion rates of patients receiving 2 doses of vaccination at the appropriate interval. And what was fantastic was 100% of those patients developed seroconversion. So this was very reassuring. So I want to go a little bit into details of the Clarity vaccine sub-study. So basically, this is one that look at whether patients with IBD treated in infliximab have an attenuated serological response to a single dose of the COVID vaccine. So this is a nice study to show that the green shows actually the antibody titers after infliximab, and the orange shows the antibody titers after vedolizumab. So whether it is Moderna or Pfizer, we find that the trend is the same. Somehow, for whatever reason, after one dose, the antibodies, at least for the spike area, was lower for patients who were treated infliximab versus vedolizumab. And it didn't matter whether you're using whichever RNA vaccine. So when they did a multivariate regression analysis, they found that factors that were associated with lower antibody concentration were patients who were older, as we expect. And consistently, we keep seeing that patients who are on immunomodulators seems to mount a lower response. Some patients with Crohn's, and interestingly, some patients who smoke. And whereas, interestingly, non-white ethnicity was associated with higher antibody concentration. This is a look at percentage seroconversion after one dose of vaccination. And you find that, in general, patients with vedolizumab had a higher level of antibodies Patients with vedolizumab and immunomodulators had a smaller level of seropositivity. This is also replicated in patients in infliximab. So in patients with infliximab, the levels were already lower than vedolizumab, but if they were on combination therapy immunomodulator, they do worse, or in the sense that they had the lowest seroconversion rate. And this was true whether we were to use Pfizer or Moderna. So interestingly also, if you put a patient and they on one of the two vaccines and they develop antibodies, you find that the antibodies in patients with infliximab tend to drop after 3 weeks after the first vaccine dose, whereas those with vedolizumab tend to hold on. And the ones, of course, in orange is vedolizumab, the ones in green is infliximab. And that was quite interesting. However, if you dose the patients with 2 doses, for example, if you look at this cartoon on the left, one dose one dose on a patient infliximab, the levels are here. 2 doses bring it up here. Similarly, if a patient who has been infected with SARS-CoV-2 and they get only 1 more dose of the vaccine, the levels are equivalent to 2 doses of vaccine. So that's quite interesting. And this is borne out by whether the patients were on infliximab or vedolizumab. It's quite interesting. So the author's conclusion on the Clarity vaccine sub-study was that infliximab is associated with attenuated immunogenicity, at least to a single dose. Immunomodulators for sure blunts the immunogenicity rates to both the vaccines. And vaccination after infection or a second dose of vaccine led to seroconversion in most patients. So that's important to know that I think in our patients who are on anti-TNF or even vedolizumab, I think we should tell our patients that except for those who have been infected by COVID, they should really go for 2 doses of the vaccine as scheduled. And it's also important not only that they go for the second dose of the vaccine, that they receive it at the appropriate time. So if it's Pfizer, it should be 3 weeks after. If it's Moderna, it should be 4 weeks after. I understand in many jurisdictions, including the UK, that because of the lack of supply, at least in the initial part, that they've delayed it to 6 to 8 weeks for the second doses. So switching gears to the American study looking at serological responses to the mRNA COVID vaccines. This is basically to show that these are the patients, all IBD patients, they receive either monotherapy TNF or monotherapy vedolizumab plus minus combo therapy, and some with ustekinumab. Find that all the patients, whether you look at them through, depending on which antibody you study, total IgG or the IgG specific receptor binding domain, all the patients who completed 2-dose vaccines had positive seroconversion. And 2 patients, again, just because they had prior COVID infection, they achieved very high levels after a single vaccine dose, mirroring the Clarity vaccine sub-study. And you find that actually, if you look at this cartoon here, really after within 1 week, you find that the levels go up. Within 2 weeks, they do very well. But certainly, is really a huge difference when they are 1 week after the second vaccine dose. So I think for our IBD patients who are precious, who are already on a lot of biologics, we should really emphasize the need for us to keep to the second vaccine and to really get them on time. So these are comparisons of the antibodies in patients who have received 2 COVID vaccines and looking at different medications. So here they see a subtle difference that perhaps, and it's different from kind of opposing conclusions, that in vedolizumab patients, they saw the titers a bit slightly lower than those with anti-TNF, as opposed to the Clarity study. So if we take a step back and look at all this immune activation after vaccination, be it with the vectors that attenuated or the mRNA vaccines. I think we should remember that all these vaccinations, like we said, we've been paying attention to what has been produced in terms of neutralizing antibodies. But do remember that actually they do also activate cellular immunity. So, and this is important because although sometimes in our patients, they have some, like my patients are a little bit, sometimes almost, I would use the word itchy, because they will get the vaccination and then they go and, especially those on biologics, and then they find that the levels are, yes, they have some levels of neutralizing antibodies, but not too much. And then they start a frenzy to ask whether are they really protected. So I think the answer I tell them is that, yes, it's good to have very high levels of neutralizing antibodies, but they are again not absolutely required for immunity against COVID, because cellular immunity itself also does play a key role, especially in RNA-derived vaccines. And it's interesting because we what we're trying to say is that it's like hepatitis B vaccination. More than 100, we said you're really definitely protected. 10 to low 10 to about 100 sometimes, I think you have the ability to perhaps mount a response when the Hep B virus comes back in. I think because there's an implication also on how cellular immunity will wake up. So I think the analogy, and I've spoken to a lot of vaccine virologists, and they think that perhaps we shouldn't sweat too much about if the neutralizing antibodies are not too high, as long that they are present, because we think that they think that the cellular immunity will kick in if the patient gets exposed to the COVID virus. So, okay, I'm going to finish by talking about timing. Really, we look at the IOIBD and the American College of Rheumatology. Basically, the recommendations are very consistent. When is the best time to vaccinate IBD patients? The answer should be at the earliest opportunity. You should not defer the vaccination just because the patient is starting to receive the immune-modifying therapies. Really, most professional organizations will say IBD disease activity should not impact timing, although a few will say perhaps it's best to do it when they are quiescent. But I think sometimes when the disease is florid and you need to hit the patient very hard, I think anytime is a good time for the patient to get vaccination. So I'm going to talk about also that really you could administer the vaccination anytime, whether it's induction or maintenance therapy. And I think we should always emphasize that to the patient, that they shouldn't get too frazzled. Okay, so I'm going to just finish off with a few key takeaways. I think the risks of COVID vaccination in IBD patients are very low. So any patient who's receiving biologics, immunomodulator, or steroids, the effectiveness is known to be attenuated, but certainly not abolished. So we think that even partial protection will be of benefit, because especially now we are judging protection by neutralizing antibodies, looking at just the humoral aspect of this immunity. Don't forget there's another aspect of cellular immunity. I think there's no difference between the current approved vaccines out there. I think we should just accept whichever vaccine that's made available in your jurisdiction. The only caveat would say that live attenuated vaccines at the moment should remain contraindicated, and certainly whatever regime that the original vaccine comes with, its recommendation should be strictly enforced in our IBD patients, especially those on immunomodulators. So in short, again, to emphasize, and I can't say it more, that IBD patients should be vaccinated at the earliest opportunity. IBD patients will call me every week to ask me when should they get vaccinated. The standard answer from my nurses, my nurse clinician to them would be, the moment you get it, the moment you have an appointment, just go. And in Singapore now, if you're 60 years old and above, you could just walk into a vaccination center, register, and get your vaccination on the spot. So, of course, we did say that perhaps when the disease is quiet, maybe that's a better time. But really, I don't believe that it should be deferred. So, patients who have previously contracted and recovered from COVID should also receive vaccination. At least from the Clarity study and the CARE study, you're wondering whether just one dose is sufficient. But if you're in doubt, please go for 2. And I think at the end of the day, I want to emphasize what Sue has mentioned, that yes, you get vaccinated, you should still adhere to protective measures, hand hygiene, masks, etc. Because the other takeaway that I didn't put in is that vaccination does not prevent you from getting infected. But if you get infected, number one, you're more likely than not that your infection is asymptomatic. Number one. Number two, your risk of ending up in ICU is so much low, to the tune of 80 to 90% improvement, as opposed to those who are not vaccinated. And perhaps now they are also talking that perhaps this, at least for the RNA vaccines, there's even protection for all the very difficult variants that are emerging, like the Deltas. So the fun fact before I finish is that a lot of my patients tell me, oh, after the vaccination, my arm was tired, I couldn't move, I get fevers and all that. And they were so excited, saying that maybe if there was a lot of side effects from a vaccine, maybe the vaccine's working a bit better. So the reality is, I hate to bust their bubble, but at least from this study, from the yellow fever study, that systemic AEs are not associated with vaccine viremia and does not impact immunogenicity. So that's what you might have to tell your patients. So thank you very much once again.